MedCram.com.
Well, welcome to another MedCram COVID-19 update. So I've been pretty excited about a couple of papers that have been published in the last year or so, particularly this one titled Infrared Light Therapy Relieves TLR4 or Toll-like receptor 4 dependent hyperinflammation of the type induced by COVID-19. Now, this was published back in 2021, but the full import of it really wasn't made that apparent until we've had some recent publications regarding Toll-like receptor 4 and spike protein. So the question is, could sunlight neutralize spike protein toxicity? And that's the question that we're going to try to tackle today. So for those of you who follow us at MedCram, you'll know that we published a video recently talking about the direct toxicity of the spike protein. And in that video, we talked about a paper that was published that looked at specifically a monkey cell on a petri dish. And in that experiment, what they did was they took the spike protein from the SARS-CoV-2 virus and they gene sequenced it, put it into a viral vector called AAV9, and had it infect a monkey heart cell on a petri dish. Monkey cells don't have ACE2 receptors that are compatible with the SARS-CoV-2 spike virus because they infect human ACE2 receptors. So they did infect this cell in a different way, but the point is that when the spike protein was made in the monkey cardiac cell and the spike protein went to the surface, it induced inflammation, and that inflammation was found to be induced via the innate immune system, and specifically with a protein called Toll-like receptor 4. And that was the mediator, it was felt, as what was causing this. This is a protein on the surface that attracts natural killer cells. And these natural killer cells causes inflammation and enlargement of these myocardiocytes in the monkey cells on the petri dish. That as opposed to a regular human coronavirus, which does not usually cause COVID-19. It's basically a cold virus. And those spike proteins did not do anything in terms of causing inflammation in these monkey cardiac cells. So the conclusion was that there was something innate, something specific to the SARS-CoV-2 spike protein, which was causing inflammation that was independent of ACE2, number one. And number two, it was using the Toll-like receptor number 4 to do its dirty work. And so you can see why, if you were to find something that could actually ramp down the TL4 induced inflammation, you might have something here of benefit. So we've talked before about the two arms of the immune system. There is the innate immune system and there's adaptive immune system. And as you can see here, the natural killer cell, which seems like it would be part of the adaptive immune system, is actually part of the innate immune system. And it is through that Toll-like receptor 4 on that natural killer cell that this type of inflammation is being carried out. So for those that follow us on MedCram, the use of light, not only in terms of vitamin D, but also near-infrared radiation, should not be a foreign idea. We've talked about this in our very popular Light as Medicine video, which is now approaching over 3 million views. And I highly, highly recommend anybody interested in this topic to watch that video. We go over a lot of questions in that video, questions that you may have about exposing yourself to sunlight, going outside, and we answer a lot of those questions. For those of you who have watched it, you'll know that the way that we've discussed this is that near-infrared radiation from the sun during the day can cause intramitochondrial production of melatonin based on a paper that was proposing this by Scott Zimmerman, a light engineer, and Dr. Russell Ryder, who is a researcher and executive editor of Melatonin Research. And in fact, we made a lot of those theories and ideas known in our video, The Case for Sunlight in COVID, that we published not too long ago that's gotten well over 100,000 views, where we talk about all of those. What we're going to talk about today, though, is completely outside of that. So this is adding to the body of literature that we've already discussed in terms of the benefits of vitamin D in sunlight exposure and the benefits of near-infrared radiation and how that mitigates oxidative stress, particularly in the mitochondria. Today, we're going to talk about how near-infrared radiation actually puts the dampers or puts the brakes on Toll-like receptor 4 mediated inflammation. And they did a very interesting experiment that we showed you here at the top of the video, and we're going to get into a little bit more of the details. But first, let's talk about near-infrared radiation because some of you may not know what it is that we're talking about. So if you look at the solar spectrum, you've got visible light here in the middle, and only 39% of the energy from the sun is in that visible spectrum. Of course, we know about ultraviolet radiation, but on the other end of the spectrum, we've got infrared, which makes up the bulk of the energy coming from the sun. Today, we're going to talk about specifically this area here, which is IRA, or what's known as near infrared radiation. This is a low frequency type of energy. And as you know, if you pull up to a stop and that car behind you or next to you is playing that loud music, what you're typically going to hear is that low frequency boom, boom, boom. And that's because low frequency energy can penetrate very well solid objects. Objects, for instance, like your skin. And so near infrared radiation can penetrate into the epidermis, the dermis, the subcutaneous tissue, depending on the wavelength, and it can be perceived as heat. Now, if you look at the actual amount of spectral irradiance, or the amount of watts per square meter at the nanometer, you can see here wavelength in terms of nanometers, that there is a huge amount of energy that we're talking about here in the near infrared spectrum. And if we look at that, we can see here that near infrared, which is this area up here, is the type of radiation that penetrates the most deep down into the subcutaneous layer, even past the dermis. In fact, there are some articles that will even show you that it can penetrate up to 8 centimeters. This is the reason why nurses in the hospital will use near-infrared light to identify blood vessels that are deep into the skin, because near-infrared can penetrate down that deep. It gets absorbed in the areas where the veins are, and what comes back is a nice little outline so the nurse can get the veins cannulated when they need to. Based on that information and the physics and the optics of the human body, what you're looking at here is a graph in the black line of the total number of human cells in the body as you go from birth to 80 years of age. What you're seeing here in red is the amount of cells in the human body, therefore, that are amenable to penetration by near-infrared radiation. You can see that is a large majority of the cells in your body that can have access to near-infrared radiation coming from outside of your body. Now, this may seem hard to believe, but in fact, it is the case based on the optics. In fact, even the brain has access to external near-infrared radiation from just regular light. And this is again from that paper that was published by Scott Zimmerman and Russell Ryder, showing that sunlight can penetrate through the bone. You heard me correctly. It can penetrate through the skull, and when it hits the cerebral spinal fluid, diffuses and gets to these areas of the sulci in the brain, which then capture this light as it rebounds deep down into these crevices and stimulate all of this surrounding gray matter, which is at the top and near the surface of the brain. Now, that may seem far-fetched, but for those of you who remember medical school, when we learned how to do physical diagnosis, one of the things that we used to do to see whether or not somebody's sinuses were open was to shine a light on the surface and see if the sinus area completely illuminated. So obviously, this is light penetrating not only the skin and the subcutaneous tissue, but actually the bone, and then illuminating and then coming back outside that bone and that skin so you can see it. Here we're placing the light on the frontal sinus, and that's here in this area here. You can see the frontal sinus is easily penetrated by light. Here in this situation, we've got a light here on the maxillary sinus. It is going through the skin, through the bone, and then through the hard palate, and you can see it here on the inside of this gentleman's mouth, and that's this area here. So we're going kind of like this. The light is going through here. So clearly, this light can penetrate through bone. Now, even more so is if you're outside in green areas, the leaves and the trees can actually reflect near-infrared radiation much, much better. So you can see here, when you're looking at the spectrum of the sun directly, there is a modest amount of near-infrared radiation, as we talked about. That gets much larger when you're talking about reflectivity off of green leaves. And then finally, what gets into our eyes, ends up in our retina, penetrates down into our skin. So with that in mind, let's talk about this paper that we started off with at the beginning. So again, they're looking at to see whether or not near-infrared or infrared light can relieve the type of hyperinflammation that we're seeing in COVID-19 via specifically the TLR4 dependent. Remember, this is exactly the type of mediation that we saw in this experiment, where we actually saw toxicity directly from the spike protein. And so the question is, can near-infrared light perhaps block this mediation so that we might be able to reduce the toxicity directly from the spike protein using sunlight? So what they did was they did an experiment. And let's talk a little bit before we get to the results about what happened in this experiment. So what they did in this experiment is they took something called HEK cells, number 293, and these are specially made human cells that are equipped with all of the machinery of the TLR4 protein and its cascade. So what happens is that when the TLR4 or the toll-like receptor 4 gets activated, it then causes a transcription of certain genes in the nucleus of that cell, which is here in the middle, and it causes the production of a number of things. First of all, it causes the production of cytokines, such as AP1 and NFK1. But it also produces, and this is by design, something called SEAP. And basically, this is an alkaline phosphatase enzyme that will turn the solution that the cells are in blue. So we'll make that blue so you can remember exactly what it is. This will be important as we talk about this later. So in other words, the thing here I want you to remember about these cells is that when the TLR4 receptor is activated, the liquid that the cells are in are therefore going to turn blue. So blue is a surrogate for inflammation. If something looks more blue on the Petri dish, it means that this whole pathway is being activated. So why would this occur? What are some of the stimulators of the toll-like receptor 4? Well, one of the big things that will do this is something called LPS, lipopolysaccharide. It's a component of bacteria. So if somebody gets a bacterial infection and it starts getting broken down, the little pieces of that bacteria contain something called lipopolysaccharide, and lipopolysaccharide will activate TLR4, which is important. Again, this is the innate immune system, so it doesn't really matter the specific proteins on the surface or what type of bacteria it is. Just the fact that LPS is there is a problem for the innate immune system. It will stimulate the innate immune system and through the natural killer cells try to attack it through this TLR4. So LPS will do it. But as we showed last time, the spike protein will do it, specifically the SARS-CoV-2 spike protein. Not the regular coronavirus one, as we mentioned, right? We looked back at that monkey cardiac cell in the Petri dish, and it was the SARS-CoV-2 spike protein that initiated the TLR4-induced inflammation, but it was not the regular coronavirus that gives you just a cold. So what they wanted to show, and this is in fact what they did show, is that when they gave near-infrared light at about 6 watts per meter squared at around 720 nanometers, what it did was that it was able to basically block TLR4 activation going to the nucleus and causing transcription of all of these factors. So basically it shut down AP1, it shut down the production of SEAP, which turned the color blue, and it shut down NFK1. Let's show you those results. Let's take a look here. They put the cells into these little wells and they add LPS. That is the lipopolysaccharide that is going to cause inflammation. And notice here that the control group looks kind of pink. So it's all pink, no LPS, that's how it looks. Then they add the LPS and what happens? Again, it turns blue. Like we said it was going to turn blue. And that's because that alkaline phosphatase or that SEAP is being produced because there is transcription occurring in the nucleus. So then what they did was from day 2 to day 4, every 12 hours for about 10 minutes a day, they exposed those cells in this liquid to infrared radiation. So again, this is LPS now plus infrared radiation. And notice what's happening. Notice that instead of it being blue anymore, it's now starting to turn back pink. And in fact, what you will see here in some hard data is that inflammation is being shut down in these cells that specifically just really have the toll-like receptor activating and causing all of this issue. So here's a graph showing that light intensity as it went from 0 all the way to 6 watts per square meter. There was a reduction of about 40%. From 100%, which was the total inflammatory response when there was no light being given. Notice here with IL-6 secretion, which is a surrogate for inflammation, as you can see here, no LPS, hardly any IL-6 secretion. LPS given, that's going to stimulate the toll-like receptor 4. way up here, and you're going to have 100% of the IL secretion. And then you add infrared, and there is a huge drop down in IL-6 production. And so what the authors of this study want to try in COVID-19 patients is potentially a near-infrared IR panel. In this case, 2,000 watts per square meter here, 1,500 watts per square meter, and at the same time, having the patient be subjected to near-infrared radiation. And you can imagine if it's penetrating 8 centimeters from this side and 8 centimeters from this side, you're pretty much getting the whole body exactly where it needs to get that kind of treatment. Now, obviously, you got to remember here that we're talking about a petri dish, we're talking about cells, we're talking about things that are benchtop, and there's a big difference going from there to reality. But the fact of the matter is that there actually is a lot of research and epidemiological research which has shown that COVID-19 outcomes are tied to latitude. And for that, I would highly recommend that you watch our video on light as medicine and the case for sunlight in COVID-19. And what you'll learn from that is that there is a tremendous amount of evidence that would seem to indicate that there is not a lot of risk and potentially a lot of upside in getting our patients who have COVID, even those who are sick and don't have COVID, maybe they have other viral infections, to get them outside and exposed to near-infrared radiation from the sun. That doesn't mean that you go out directly in the sun when it's high up overhead and you're getting a lot of ultraviolet radiation that could cause skin damage. But it means getting outside more than we have been as a society, and maybe the reason why we're not getting the kind of outcomes that we should be getting with pandemics and viral infections and things in general. In fact, if you look and see how we did things 100, 200 years ago, it seems as though we empirically knew, even though we might not have known the science behind it, we empirically knew that getting out into the sun was beneficial enough that when they build hospitals, they would build them specifically in ways that the patients could get outside to get sunlight. I remember talking to a neurosurgeon who trained in Seattle, and the hospital that she trained at had a solarium. This thing was built in the early 1900s, and that's what they were doing at the time. They may not have known the science, but they could see empiric results, and this is the reason why they recommended getting out into the sun. In fact, a notable health reformer back in the 1800s said this: "The feeble one should press out into the sunshine as earnestly and naturally as do the shaded plants and vines. The pale and sickly grain blade that has struggled up out of the cold of early spring puts out the natural and healthy deep green after enjoying for a few days the health and life-giving rays of the sun. Go out into the light and warmth of the glorious sun, you pale and sickly ones, and share with its vegetation its life-giving, health-dealing power." And that was published back in 1871 by a lady named Ellen G. White. Now, what was going on back at that time? If we look at near-infrared human exposure, as predicted here by Zimmerman and Ryder, you can see here that near-infrared radiation, which is the driving force behind the study findings here, has gone down dramatically from 1800 down to present. And that is because we are going outside much less, from 50% outdoors down to 7% outdoors. And we're no longer using incandescent light bulbs. We're using LED bulbs. And more specifically, plain glass windows, which used to let a lot of near-infrared radiation in, are no longer doing that. These low E-glass windows can actually be a very efficient blocker of near-infrared radiation. First, let's look at the bulbs, the LED lights that are specifically designed to make sure that no energy is lost. You can see that here with the red line. There is no emission of any kind of near-infrared light from LED bulbs. However, if you look at incandescent bulbs, you can see that in fact most of the energy that has been given off in incandescent bulbs is in the near-infrared area, and only a small portion is in the visible spectrum. This kind of looks somewhat like this distribution, which is actually the solar distribution. And of course, those incandescent bulbs are going away pretty quickly. With them are being replaced this clear glass, which allowed quite a bit of transmission of near-infrared light, close to 90%. With high solar gain low E, moderate solar gain low E, and low solar gain low E, you can see here that there are respectively lower and lower amounts of near-infrared radiation that's being allowed through. So I have to get a little excited about this, and I'll tell you why. It's because the benefits of sunlight, the more we study it, the more we realize that it's more than just vitamin D. I think it would be a mistake, as I've said before, to think that because you're taking vitamin D supplementation, you don't need to go out into the sun. We're starting to see evidence that sunlight in the near-infrared radiation spectrum can potentially stimulate melatonin production in the mitochondria on site right where it's needed the most to reduce reactive oxygen species. And now this paper seems to indicate that it may reduce the very mechanism that causes the spike protein to be toxic to cells, at least to monkey cells in a petri dish. I think there needs to be further research on the potential use of sunlight in long COVID. There seems to be some evidence that long COVID may be a result of prolonged spike protein interactions. And I think that it would be very easy to do a study that looks at sunlight exposure and the effects of long COVID. In fact, there's been some studies that have looked at latitude and indirect studies, but I think it is high time now to start looking at the sun as a major therapeutic source and to do a randomized controlled trial. Maybe not placebo, that might be difficult to do, but a randomized controlled trial looking at the benefits of getting outside and getting sunlight and its effects on COVID-19, but not just COVID-19, but in fact, a lot of disease. If you enjoyed this video, I encourage you to join us at medcram.com, especially if you want to see these videos without commercials. People often ask, who pays us to make these videos? Well, MedCram is completely supported by viewers that watch on YouTube, but more specifically, those of you who come and support us at medcram.com, where we have a number of courses and also continuing education as well. All of our courses on COVID-19 are free, but we also have premium courses and reviews, including ECG, Basic Metabolic Panel, and vasopressors, and many others that offer continuing medical education units and credits. Thanks for joining us.